Hi, everybody. Welcome to this month's live Q&A with Dr. Green and Dr. Cat. I am Angela. I'll be here, as I always am, moderating this month's session for you. I'm going to let our doctors introduce themselves. And for everybody who's new, please put your questions in the chat so that we can get started answering those questions. And I'm going to let Dr. Green take it away.
Okay. Hi, my name is Mike Green. I am an OBGYN, and I also happen to be the Chief Medical Officer of Winona. And it has been my privilege to do women's health for the last 25 years of my life. And really excited to be here to answer your questions. I'm one of the, folks that started Winona, and really excited how far we've gone and how much good we're able to do for y'all. So this is all about answering your questions. So please type your questions in the chat because it gets really uncomfortable when there's no questions and then we just chit chat. Just before you came on, we were talking about my old senile dog, but I don't think that would be exactly what you want to hear about. So type your questions where you get to hear about Yogi. Take it away, Dr. Cat.
Okay. Hi, everyone. I'm Kat Brown. I'm also an OBGYN physician. I was hired by Dr. Green a few years ago. I joined Winona in December of 2021, and I just recently became the medical director. So I'm helping to curate some content on our website and represent Winona on some webinars and podcasts and things like that. So also have dedicated my life to women's health. A little bit shorter than Dr. Green. He's a little bit more senior than me, but about 20 years now that I've been practicing OBGYN. And really now I have a vested interest in menopause care and perimenopause because I'm going through it with all of you at the same time. So this is definitely at the forefront of my brain right now. And the interesting thing is each month we normally go over a topic that we like to discuss. And this month, we only have a couple days left in March, but March was Women's History Month. And so I thought it might be worthwhile to talk about that. And actually this month I went into my kids' school. They do like this Read Across America week where they have guest readers. And I didn't tell my kids, but I was a surprise book reader for my son's class and read some books about like famous women that have done cool stuff. So like Women's History Month is a time for us to go back and look at and see some of the women pioneers. 30, 40 years ago, our lives would have been very different. Like we wouldn't have been able to have a credit card or own property and needed your husband's permission to do many, many things in the country. But now, especially in our field, Dr. Green, I think that like our gender mix of female versus male OBGYNs, like now the new grads coming out of med school, there's more women going into this field. But years ago, there weren't very many female physicians. And now, the playing field's getting leveled a bit. So just something worth noting. And hopefully some of the women on the call tonight have done a little bit of learning about Women's History Month and talking about that. And as far as Women's History Month goes, I think that this is also a really good time for women's health because now we're noticing more is in the media, more knowledge is being shared. More doctors are out there on social media trying to educate patients, but there's more of a focus on women's health as well. And so I think that this is a good time for you to be a good advocate for your own health and to learn as much as you can because now all these resources are available to you. So something worth talking about. Women's History Month. So anyway.
Love it. What I need to know, Dr. Cat, what interesting things were on that sheet that you have for your kids' school? Anything?
Yeah. Well, I mean, the first woman physician to earn her medical degree was in 1849. Her name was Elizabeth Blackwell. And it's interesting. The first woman to run for president of the United States was actually in 1872. And I don't remember ever learning about this.
What?
Somebody named Victoria Woodhull. I don't think we ever learned because she got lost.
They skipped Victoria.
The history books are written by the winners, right?
I guess.
But this has, the first woman to win a Nobel Prize was Marie Curie. And first female self-made millionaire was Madam C.J. Walker, which actually there's a Netflix show about her, I think, or maybe it's on Hulu. She made like a hair serum and, became an entrepreneur. She was like one of the first women to market like a hair product to help with, Black women's hair and help with styling and things like that. But yeah, there's a lot of interesting things. Like the first woman ever ordained as a rabbi in 1935. First woman to ever get a Grammy was Ella Fitzgerald in 1959.
Oh, wow.
Yeah, there's a lot of cool information, like, things you didn't know. And I actually got my youngest is a girl, and she's 7. And one of the things I got her for Christmas was this book series, and it's called Goodnight Stories for Rebel Girls. And it's like every page has a little brief history of a woman who's done something cool. And it has things from like, dancers to politicians to athletes, all kinds of people. But she loves it. And she's, always wants to see the pictures and wants to know who lives in America, who's elsewhere. It's really neat, to learn about these things.
I love that. That's cool.
Yeah.
Yeah, because you forget about all that when you learn it at some point and then you forget it all.
Exactly.
And then, maybe it comes back with Winona's products when you have your brain fog, right? Maybe. Maybe it comes back. Maybe. Okay. Do we want to answer some questions, the two of you?
Let's do it, because they don't want to hear about my dog. So yeah.
Oh my God. We have stories, everybody. Look out. Okay. Suzanne has a question. She wants to know, what are the benefits of using a daily cream versus the estrogen patch with micronized progesterone?
So really, it's a matter of preference as far as what you feel like would fit into your lifestyle better. So in my opinion, for women who have a history of sensitive skin, or maybe you've reacted to Band-Aids or medical tape, like when you've had your blood drawn and you've gotten rashes from that, maybe the patch wouldn't be so great for you, and the cream might work better. They're just as efficacious and just as helpful for patients. It's just a matter of what fits into your life. So would, applying a cream once a day work better, or would you like to set it and forget it and have the patch on and, change it midweek? So it's really about that. It's not, one is not superior to the other. So.
Okay. Oh, Suzanne is also sharing that she's used DHEA supplements and had a preset significant breakouts on her face. Is that normal? And if so, does it subside with use?
Yes. It's a pretty common side effect for a lot of our patients. Not everybody experiences it, but most women will notice, some acne that might develop. And if you don't get acne, you might notice that the quality of your skin might change, like might feel a little bit oilier. Sometimes your scalp can feel a little bit oilier after taking DHEA, but it's usually a temporary phenomenon as your body gets acclimated to the medicine. And your body starts to, kind of roll with it, and those side effects tend to subside with time.
Okay. Let's see. April wants to know, can you take a supplement for menopause along with HRT?
So I'll grab that. Well, the short answer is yes. The long answer is probably don't need to. So the HRT should be sufficient to take care of all the symptoms of the menopause transition. And so a lot of people try different supplements, and they help a little bit, they don't help much, and then they come to Winona. And so this is a common question. And the answer is it's safe to continue them, but for most people, they'll find that they're not necessary anymore because the HRT takes care of all those symptoms. And so, it's better not to take stuff if you don't need to. It's safer. And it's also, some of those supplements are pretty expensive. So once the HRT becomes effective, for most people, they can stop their supplements, save them a lot of hassle, and save them some money. Yes, it's safe to do, but for most people, it's not necessary.
Okay, well, Barbara has a really interesting question for us that I'm sure we're going to like to unpack. So Barbara is saying that she was happy to find Winona this week and is waiting for her prescription in the mail. She lives in New Jersey, and she has had some great doctors. However, not one of them has ever discussed HRT or even asked how she was doing with menopause, for shame. And she says her friends have had similar experiences and wants to know what we think the reason is for that, and how did we decide to create the brand?
So,
since it's about creating the brand.
Yeah, I want to jump on that. So, because I was involved in some of the original discussions. the sort of history of this, actually, it was kind of interesting. It was actually the month before COVID hit. I remember it because I was moving my son up to Washington State, and he had a really bad flu, cold, and he had gotten it from a friend of his who lived in Corona, California. And we were joking that he had this coronavirus that we had heard about in China. So, but anyway, that's when I moved up to Washington, that's where I met with some of the founders. And we were discussing at the time starting telehealth. We were kind of brainstorming on what we would want to do. And ultimately, one of the things we talked about was at that time, HIMSS was becoming very successful. They were one of the sort of pioneers in this. And they were basically doing erectile dysfunction for men. And we were like, gee, they're doing this and nobody's doing anything for women. It's like, it's the same demographic. We should maybe think about doing hormone replacement therapy for women. And that was sort of the seed that got us thinking about it. And when we looked into this, it was like, there's really nobody in this space. And it's really an underserved area. And it has been not just in telehealth, but really throughout, as your question says. We can talk about, it's kind of interesting history of why people are so reluctant to talk about HRT, and so many doctors are reluctant to prescribe it. But it's really a big sort of hole for healthcare. And women are told to just sort of suck it up, and it's just part of getting older, and it's ridiculous. And that's what it's like, it's not fair. It's like, well, men aren't told to suck it up when they can't get an erection. Why should women be told to suck it up when they're having hot flashes and night sweats and they can't sleep and, they're having all these issues? And so that was kind of the original thinking that got us started down the road of doing hormone replacement therapy. So it's kind of like the little seed that started it all. But so it goes kind of way back to whatever that was before COVID, quite a bit ago. Kat, you want to talk about why people are so afraid of HRT?
I mean, it really comes down to comfort and experience, but I also think that we're still fighting the after effects of the World Health, the Women's Health Initiative study, the WHI. So, I mean, even when I was a resident being trained to become an OBGYN, learning about menopause and learning about HRT, we were told, well, just memorize this stuff for the test. You're never going to use this. We don't prescribe hormones anymore. So don't even worry about it. And I kept thinking, that seems weird. Why would there be this body of knowledge that we're not going to utilize anymore? So in general, so many people in the world, family doctors, OBGYNs just got out of practice using HRT because there was this general fear, surrounding hormones that was just pervasive everywhere. And everyone just got so afraid of using it that they got out of practice. And it's really not something that's focused on, I feel like, in medical education that much. But hopefully that tide is changing, because now if women demand better care, then, doctors are going to have to come, they're going to have to get more comfortable with it. But, the interesting thing is, we prescribe birth control like it's nothing throughout our careers. And birth control has so many more bad side effects and bad outcomes than HRT does. But, most doctors out there don't think about that comparatively. They just feel like there's this comfort level, and they're still even prescribing birth control for women in their 50s for menopause symptoms when it's really not the ideal treatment. So, I think it's fear and lack of experience, right?
Yeah, it's interesting. I've had many patients now over the years that come and say, I talked to my doctor about it, and they say, oh, I don't prescribe HRT. And so then, we get them started on Winona, they feel great. And then 3 months later, they come back and say, hey, I need to cancel my prescription. Thank you for everything you've done. But my doctor saw how much better I was doing on it. And so now he's willing to prescribe it. And I'm like, good, one more doc's doing it right now. So that makes me really happy.
I love when we get those messages, because then I feel like, we're kind of doing an indirect education to their provider too. And opening their mind a little bit to be able to offer it to other patients in the future. So it only helps the greater population when that happens.
I want to just share with you on this note that recently Winona was doing a lunch and learn for all of you out there. We were doing some corporate wellness discussions about Winona in your workplace and offering it to businesses. And I know, Dr. Green, you mentioned this, probably Dr. Kat as well, that Kaiser is not always the most helpful when it comes to HRT, and even considering, women who are in need of that if you are a Kaiser patient. And so we had a whole session with a space out in the Simi Valley of people who said, yeah, we have Kaiser, they won't help us, we can't get HRT, so we're so grateful for Winona. Thank you for coming to our place of business and offering your services, because, you know, they just, for whatever reason, won't, you know, they won't offer it to people. So
yeah, Barbara, yeah, I know you're in New Jersey, but in California, Kaiser is the biggest healthcare provider in the state, and also they're pretty prevalent in Washington and Oregon, and they basically, as a rule, do not prescribe HRT, which is just wrong. I mean, how can you not do that for women? It's, to me, it's sort of atrocious. But I'm glad that we can help fill the gap and get women the care they need.
Yeah. Okay. Susan is asking us, is DHEA used topically is DHEA used topically, is it beneficial rather than oral, since oral gives her cystic acne?
Ooh, I'm going to grab that one too. So
you look so excited. Go ahead.
Yeah, I was just talking to someone about this. It's just this really interesting conversation. So when we were starting Winona, one of the things I said is, you know, it'd be really cool if we had like an all-in-one cream that had our estrogen, progesterone, DHEA. You just use one thing and it would work. And the compounding pharmacist told me, you don't want to do that. And I said, why? They said, DHEA doesn't get absorbed through the skin. Like, well, I have heard of people using compounded DHEA. He goes, oh yeah, we compound it for people, but it's a placebo. It just doesn't work. And I talked to a couple compounding pharmacists, and that's what they told me. They said, yeah, we provide it for the docs that prescribe it, but we always roll our eyes when we do because we know it doesn't work that way. So unfortunately, DHEA doesn't work topically. It's just too big of a molecule to get absorbed through the skin. And so these DHEA compounded creams are really, unfortunately, placebo creams. Now there are DHEA vaginal creams that do help, and there's actually some pretty good data for that. It's not something at this time that we're that we have in our arsenal, but that is sort of one exception where a topical DHEA can work. But a DHEA cream, like throw it into our estrogen progesterone cream, to me that sounded like a great idea, but we're not in the business of providing placebos and pretending they work. So we want to make sure the medicines we use work. And so that's why we don't use it that way. It's a great thought, but unfortunately it just doesn't work.
Okay. Our next question, someone is saying that they're on HRT, but they still have stomach cramps even when they don't have their period. And they want to know if upping their dosage would help.
If they had stomach cramps. I was just answering a page real quick.
No,
Someone called in case anybody notices I'm in scrubs.
Yeah, stomach cramps. They have cramps.
That's a beautiful call room you have there.
It's a fake background. This is not what my call room looks like. Wouldn't that be nice?
Very like Floridian over there.
Sorry.
No, it's funny. You guys are both funny. Yes, the question was stomach cramps. If you don't have your period, would upping the dosage on HRT help make that go away?
I mean, it depends on how you define stomach cramps. I guess, it would be helpful to know. Sorry, that's another phone going off. It sounds like an elephant.
She's saying like period cramps, kind of.
Oh, like period cramps. So, I mean, if you're taking HRT and you're starting to notice period like cramps or low pelvic pain like that, even the uterus and the ovaries may respond to some of the hormones. And if it's something that you're noticing when you're first starting treatment, it's something that may go away on its own. Your organs are going to respond to the hormones a little bit. If not, then we may have to adjust the dose. And so, if you're one of our patients and you're on treatment, this is something to just open the dialogue with your doctor to talk to them about.
Okay. All right. So our next question, Christina says, if you're still perimenopausal and only have a period maybe 3 times a year, is it still okay to use the cream? She's been feeling great for 6 weeks, but got a period after 4 months and started to feel pretty sick.
Yeah. So, I mean, if you're having periods and they're starting to get irregular in that transition time while your body is starting to kind of prepare for this transition into menopause, it is safe to still take HRT as long as you're taking, if you have your uterus and you're still having menses and, as long as you're taking progesterone along with your estrogen, that's the safest way. And it's safe to continue taking that. it can be common for some women to experience some bleeding as their body responds to the hormones. But I've had some patients ask, like, is HRT going to bring my periods back, or is it going to cause me to have more periods? It really doesn't. It's just that during this perimenopausal transition, our periods can get erratic. There can be no rhyme or reason. It's just that the communication between the ovaries and the uterus, it's not in sync like it used to be. So you're not regular. It's not as predictable. And just like when we first start getting our periods and, in our early teen years, it's really disruptive to not know when you're going to get your period. And it can be pretty distressing to like be out in life or be at work and all of a sudden get a period when you thought maybe you were done and you hadn't had one in several months. So, just be prepared that, as you're going through this time and as our bodies are starting to go through perimenopause, sometimes those irregular periods can last for several years, sometimes even longer before the periods actually stop. But it is safe to take HRT during that time.
It's always good times. The mystery period grab bag.
Yeah.
Yep. Okay. Patricia. She says she's currently on testosterone cream along with progesterone and estradiol. What is the transition like coming off of testosterone and using DHEA instead? And why is testosterone so hard to get as a prescription?
Well, it's hard to get as a prescription because it is a controlled substance that's pretty widely abused by bodybuilding community, military community in high doses, not typically what we prescribe for women during this time frame, but it has to be prescribed by an in-person provider in most states, which is why we don't use it here at Winona, because we don't have the ability to do that. Because it's a controlled substance, it's very much controlled like narcotics would be and other high-risk medications. So that's why we can't typically use it. As far as the transition in coming off of testosterone, it depends on the dose. It depends on how long you've been taking it. If you've had side effects from the testosterone or not. Most women may notice a subtle difference, and they might feel like the DHEA is not as effective as the testosterone initially, but I think that most patients do very well as their body acclimates to the DHEA. I don't know if you wanted to add to that, Dr. Green.
Yeah, the other thing about testosterone is a bit of a tricky drug. It has what we call a narrow therapeutic index or window, which means that the difference between the therapeutic dose, the dose that works, and the toxic dose, the dose that gives you side effects, is really skinny. It's really easy to push past that therapeutic dose and get you into the side effect realm. And so it's kind of it's a tricky drug to do right. And so I see a lot of patients that come to us either on testosterone pellets or the creams that are having testosterone side effects because it's so hard to like dial it in. And that's one of the nice things about DHEA and the doses that we prescribe. It really will not push the testosterone outside of the normal values. So we don't have to worry about those bad testosterone side effects that people get. So it's a safer way of doing it. Clearly, we're not going to get the same testosterone levels as you are with direct testosterone treatment, but in some ways that's kind of a better thing because the thing about testosterone for a lot of people is when you first start it, it gives you this sort of euphoric feeling and you feel really good. And then after a while, the side effects start kicking in. So particularly, I hear this with people on the pellets. The first pellet or two, they feel great. And then after that, they start not feeling so great and the side effects start kicking in. So the nice thing about DHEA is that it won't do that. It's not going to give you that initial euphoria, but it's also not going to give you the long-term problems that testosterone therapy does. So there is a trade-off there. But I think, one of the safety is obviously very, very important, and it's a lot easier and safer to use DHEA in appropriate doses. Now, there are people that use ridiculous quantities, ridiculous doses of DHEA, just like people use crazy doses of testosterone. And in those doses, it'll cause the same kind of problems. But in the doses that we prescribe, we really don't have to worry about that, which is nice.
Okay, Sue has a question for us. She says she's worried about the prescription to take progesterone every day, that Dr. Google says that premenopausal women should take progesterone for 12 to 14 days per month. What are your thoughts about pre or perimenopause and daily progesterone plus estrogen?
There were a couple studies that came out somewhere between 10, 15 years ago, that said, it was really a surprise. Women that have had a hysterectomy and use estrogen only HRT do not have an increased risk of breast cancer, but women that use combination HRT, estrogen, and progesterone together have a slight increased risk of breast cancer. And so people kind of interpreted that, gee, maybe it's the progesterone that's causing a problem, and we should try to limit the progesterone exposure. And so people came up with all these different ways to do that. And one of them was to use it 12, 10, 14 days a month. Some people 7 days a month. Everyone had their own recipe. Some people tried doing it 7 days every 3 months, really to try to decrease this exposure to progesterone. And it was a good idea and well-meaning, and it made sense to try it. But in the last 10 to 15 years, studies have come out looking at that, and what they've shown is there's just really no benefit to that whatsoever, and it causes more side effects. And so because of that, we've sort of the in the know people that really follow this, menopause specialists have realized that no, we're really better off dosing it every day, because there's no benefit to do it the other way, and why take the side effects when you're not getting a benefit? And so, a lot of times the stuff you see on the internet, it sort of lags behind the latest research. And so this was sort of kind of in vogue 7-10 years ago, but really the data has come out saying it's really not the right way to do it. And so the latest thinking is that daily progesterone is really the safest and the best way to do it. So that's where this confusion and this inconsistent recommendations are coming from.
Okay, here's an interesting question. I feel like this would be a good true or false question for those of you who are going to be interested in menopause trivia. Are there different forms of estrogen in Winona's cream versus the patch?
Just slightly. So, I mean, our patches are estradiol alone, but as women, we have 3 main types of estrogen that our body creates on its own. And so in our compounding cream, you'll notice on your container, it'll say bi-est, meaning that it's 2 forms of estrogen. And so it's a slightly different formulation compared to the patch. What was it? Was there another part of that question?
Just are there just wanting different forms? That's it.
Gotcha.
Yep. All right. Okay. Alicia wants to know if we can share the exact way. So I'm guessing we need a visual tutorial. The exact way to put the cream on my forearm. Does that mean inside of my wrist, up by my crease in my arm, or both?
I wish I had my cream here, like it's at home. But typically, so here's your forearm. What I would typically do when using the cream is I take the little container and I squirt it right onto my forearm, like kind of in the middle part. You want to not hair bearing, but the inner forearm. And then I take my other forearm, and now you're going to see my tattoos, and I rub them together to rub it in. That's how I typically recommend for patients, because you could also do it with your hand and rub it in as well, but then you're getting some cream on your fingers that you're going to then wash off. So for me, I wanted the biggest bang for my buck, and I would squirt it right onto my forearm and then rub the 2 forearms together until it rubs in completely.
All right, Alicia, let us know if you need further visual aids.
So let me just kind of jump on that a little bit. The hair bearing thing is kind of just because it's kind of an interesting point. So this is a question that we get a lot, and you really want to put it on an area that doesn't have hair follicles, not necessarily just hair. So if you have an area that has hair that you normally shave, the hair, you still don't want to use it there. And the reason why is there's enzymes in the hair follicles that can metabolize the hormones. So you really want to avoid the hair follicles, not just the hair itself. So that's why the inside of the forearm, inside the wrist are good places, because there aren't hair follicles there. The inner thigh, the back of the knee are other areas that we have skin without hair follicles. So it's just kind of I think it's kind of interesting, like why? It's like, that's why. It has to do with some enzymes in the hair follicles.
And I've had some patients complain, that, other family members getting contact and getting cream exposure. So they've switched to other areas. The other thing, you said the inner thigh, the back of the knee is another good one, because there's really no hair in the knee, itself. And that, what we call the popliteal fossa, or that inside part of the knee.
Hairy knees? Are you? We don't have hairy knees. Is that what you're saying?
Well, on the outside, you might have hair, which is always a challenge for shaving, but no, it's the inside part.
The backside.
The backside, the underside of the knee.
The backside, the back of the knee. Okay. Sue is asking us, is there a best place to put the estrogen patch? Lower stomach or your butt?
The best place is where it's going to have the least friction from your clothing. So I have some patients that'll put it inside, like on the inner hip, inside where their panty line would be, or inside where a bathing suit would cover. I have other patients that put it like right on the front of their shoulder, as long as it's not going to rub on the bra strap. In general, though, if you move the site for the patch, you want to make sure that the skin thickness is relatively similar, because if the patch is put on a fattier area of our body and then put in an area where the skin is thinner and there's not as much fat deposition, the absorption might be a little bit different. So in general, you want to try to stick to the same type of thickness of the skin.
So this has nothing to do with HRT, but it's just funny because I was talking to a patient about this yesterday when we were talking about birth control options. Do you remember when the contraceptive patch first came out? There was this thing, these teenagers would wear their midriff, showing, and they'd like make sure that they had their contraceptive patch in an area where everyone could see it, and they'd proudly walk down the mall, displaying that they were on the contraceptive patch. It was just this hilarious fashion thing that was going on for a while. Anyway, I was reminiscing about that with a patient yesterday, and it just made me think about that again. It was like just crazy things that happened.
Like it was an accessory, like they're showing off the patch.
Yeah, look,
okay.
I'm on birth control.
I used to be also, I know, like I was watching old episodes of Sex and the City, and they had when you were the patch to quit smoking, like, and Sarah Jessica would always put it like out where everybody could see it, like, here's my smoking patch. Yeah, so weird, so funny. Okay, April has a question for us. Wait, did I skip April? I think April's next. Yes. She says she read somewhere that you should wait a half hour before showering or washing off after applying the cream. Is that accurate? And she says, of course, she can't remember because menopause.
Yeah, generally the 30-minute rule is a decent one, because within that time frame, typically the medication is absorbed. So I usually tell patients the 30 minutes, typically though, like once it's rubbed in and once it dries on your skin, it usually has done what it needed to do. But I think it's safe to do 30 minutes to be on the safe side.
Okay. All right, that's good. All right. Renee would like to know, she says, have patients experienced weight loss after starting HRT? If so, how long does it typically take to see results?
Yes. So typically, especially, weight loss and weight gain comes from many different factors, but for the hormonally related weight gain that many women experience in perimenopause and menopause, usually once we get your hormones to an optimal level and we get your symptoms under good control, usually then you start seeing the weight loss. It's not instant. And unfortunately, many of us, it's our human nature that we want instant gratification and we want a pill to fix whatever it is, like yesterday. So this is one of the benefits of the medication, that you have to give it some time. In my experience, usually within, like, from getting a woman's hormone treatment optimized, usually we start to see weight loss within 4 to 6 months. Sometimes sooner for some women, but on average, this is one of the last benefits that a lot of women see. They'll start to notice improvements like in hot flashes and night sweats and the brain fog and their sleep quality first, and the weight loss starts to come later. Because it's a lot of things that we're having to change and improve metabolically in your body for your body to start really working at its best and not retaining weight. Like, we're in this constant stress state when we're going through perimenopause, and our stress hormone levels, our cortisol levels are high. And what that is like our body's in this fight or flight mode. When we're in fight or flight, our body's, like, our primitive brain doesn't realize that we're ever going to get to eat again. So it's holding on to every calorie and every bit of fat for fuel for later. And we don't want it to. Despite our best efforts, we want to lose the weight. Like, our body is programmed to do the opposite. And so it takes some time to reverse that process.
Okay, we have some good questions coming in here. All right. Barbara, oh wait, I'm skipping. Patricia, pardon me, says, can we give her a rough rundown of getting started with Winona and how it works? Are labs mandatory for prescriptions? And are we able to give an estimate of costs?
So
Agree.
here, I'll do this. So it basically starts with an onboarding process, which we call an adaptive online interview. So it's similar to what we would do in the office, where we would ask you questions and you would answer them. And then depending on how you answer, we'd ask follow-up questions. And so we have an interview designed online for you to do that. So we'll ask you questions and you'll answer those questions. So this was actually kind of an interesting thing. So my first shot at this, because I designed the onboarding, there was way too many questions, because I'm used to an office practice where you hand somebody a book, if you've ever been to a new doctor, and you've got to fill out this ridiculous amount of stuff. And so I just asked all the stuff. And then, it was like, I was challenged to think, well, what information do you really need? Like, don't ask stuff you don't need. Like, it's really irrelevant whether you sprained your ankle when you were 10. I don't really need to know that to prescribe you HRT. So I really weaned it down. What's really important? And so most of the questions at first are really designed to kick you out. It's like, okay, these are things that would be unsafe for anybody to use HRT. So we make sure you don't have those things. So we do sort of the weed out questions first. We ask you what symptoms you're having. And then we ask you some other things about your medical history that's going to help us to provide a recommendation for you. So I designed this algorithm. It took me about 1,000 patients to get it right. And now it works pretty good. And so we'll get all this information and it'll give you a recommendation. This is what, we recommend. Would you like this? And we give you options of pills, patches, and creams. We show you the prices, what it would cost, a little blurb about each one and the benefits, and see what you prefer. And once we've got that all worked out, then you say, yeah, this is what I want. And then you upload your credit card. We have to confirm your ID, so a photo ID and a picture of yourself. And then that goes to us. And we look at all that information, make sure that everything's safe, and make sure that the algorithm was right. And sometimes it's not. Sometimes we change it. And if everything matches up and everything's great, then we prescribe you the hormone replacement therapy or whatever is appropriate for you. And that gets charged to your card and sent to you by mail, and it shows up in your house, usually within a week of you finishing the process. So that's sort of the big picture process of how it works. Number one consideration is safety. So most of the questions are really designed to make this safe, because quite honestly, if I relieve your heart attacks, but I kill you with the medicine, I haven't really done you any favors. So we've got to make sure that this is safe for you before I worry about fixing your problem. So once we've got that established, then we want to make sure it's going to work. And so that's kind of the idea behind it. It turns out that labs for hormone replacement are useless. And I know that's strong, and it's not what you hear online, and it may not even be what you hear from your primary care doc. But these labs for all these different stuff that people test, the estrogen, the progesterone, the sex hormone binding globulin, the FSH, the LH, all these things aren't helpful for several reasons. Number one, it doesn't really predict how you're going to do with the HRT. And number two, the numbers themselves aren't valuable because the numbers change all the time. They change from day to day, but even from hour to hour, depending on what you've eaten, whether you exercise, what's going on today, how much stress you're having. So it's just a point in time, and it really is essentially meaningless. Unfortunately, lab work has become sort of a billion-dollar industry. And there's big companies that are really pushing these labs. And then also there's a lot of doctors that haven't been well educated on HRT, and they, in a well-meaning way, they draw labs thinking it's the right thing to do, but these labs aren't useful. And the problem is, I see a lot of patients that are really suffering from their symptoms of menopause transition, and somebody, in trying to do the right thing but not understanding, ordered labs, and the labs came back normal, and they say, oh, your labs are normal, you don't need anything, and they sort of dismiss them and send them off. And it's a shame. And then we give them HRT appropriately based on their symptoms, and they feel better and they do great. And that's really the way that HRT should be prescribed. So not only are labs not required, but they're not necessary. So we don't do labs, and we discourage labs because it's really useless information, and they're expensive and they're time consuming, and why do that to you when we don't need the information? So that's sort of the process in a nutshell. I designed this to be like I do in my office. So if I were to see you in my office, I'd go through the same thing. I'd write you a prescription based on the algorithm in my head. This is the dose I think is going to work. And then I'd see you back in 3 months and say, how's it going? And either it's going great or, hey, it's not so good. And then either I say, okay, let's stay on the same thing as it's going great, or let's adjust some medications. And then if everything's great, I'll see you in a year. And if things aren't, let me know, give me a call. And we can adjust further. So that's the process. And then we touch bases every year. So again, I designed it to do, it's designed to do it the same way I do it in my office. And really, I would say that I treat you just like my office patients, but honestly, you kind of get better treatment. You have much better access to me than my office patients do, quite honestly, because y'all message me 24 hours a day and I try to answer almost 24 hours a day back. So, which is really kind of a good thing for everybody. But so that's how the process works. I think I answered that question, probably much more detail than you wanted. Sorry.
That's okay. At least you're getting the full rundown. Oh, an estimation of costs was the other component of that.
So it depends on what you choose. If you need both estrogen and progesterone, the cream is the least expensive. And depending if you get it monthly or every 3 months, monthly, I think it's $89 a month. We give you, it costs us less to send it to you every 3 months instead of every month because of labor and shipping costs. So we pass that on. So you get about a 15% discount if we only send it to you every 3 months if you get a 3-month supply. So that's on the pricing. That's the least expensive if you need both. The pills are a little bit more. The patch is significantly more. So especially if you need progesterone, the patch is $149 a month. And then you would also need progesterone, which is $39 a month. So that kind of adds up. And it really has to do with cost. So we compound the cream, we have our own compounding pharmacy, and we have these amazing compounding pharmacists that compound the cream, and that keeps the cream cost down, which is why we're able to provide that, as the least expensive option.
I have a question. Are we able I know because I order my stuff differently than probably everybody else, get the, friends and family situation working at Winona. So if you're a person in the patient portal and you want to get your prescription every month, can you select that you want it monthly versus every 3 months?
Yes. So when you onboard, we show you both pricing schemes. And we say, this is how much it costs per month. This is how much it would cost every 3 months. What do you prefer? And, either way is fine. And, it depends on whether you want to save some money or whether you want to have less upfront cost. So,
all right. So you have choices, everyone. That's a good thing. Okay. We like choices. Barbara wants to know, how do you optimize HRT?
Well, it's really by that fine tuning that Dr. Green recommended. So, first of all, choosing the method that will work for you the best. And so what you feel like would fit into your lifestyle the best, because every one of us likes a different style or cut of clothes. It's the same thing with medication, whether or not you want pills or cream or patch. And then it's that following up and reassessing your symptoms, seeing how you're feeling, if things need more improvement, and sometimes we need to tweak the dose. The algorithm that we start with works a lot of the time for many patients, but sometimes we need to go back and forth, and it's a bit of trial and error until we find the right dose for you that optimizes your treatment. So it's an individualized thing for each patient.
Okay. All right. Suzanne is asking, how do we know when our dosing is right or not quite right, or it could be better?
Really by your symptoms. So, really looking at if the symptoms that were bothersome to you that brought you to us, or if they're improving on the dose that you're taking. Sometimes there can be an adjustment phase for some patients initially, and where, you might be starting the treatment because you're suffering from hot flashes and you start your HRT, and you might notice within the first couple of weeks, you might have more hot flashes, but it's an adjustment phase. So after we get the medication on board and your body is kind of acclimated to it, then we reevaluate how are you feeling, and really look at that. We also look at whether or not there's side effects happening for some patients versus not, and that can sometimes tell us that your dose may be too high and we might need to dial back a little bit. So it's really with an open dialogue and conversation between you and your physician to tweak things and get them the best that they can be for you.
Okay. Sue would like to know if the estrogen patch or cream, if the estrogen patch or cream is the preferred method for consistent delivery with fewer side effects, and wants to know what the difference between that and pills.
Well, so I prefer the transdermal methods over pills just because there's less GI side effects. So when you have to take a pill, it has to go, you have to swallow it, it has to go all the way down your esophagus, get processed by your stomach, get broken down by your liver before the actual medicine gets to where it needs to be. Whereas if you use a medication through the skin, it's getting absorbed right into the bloodstream through the skin. So my preference is for transdermal, but that doesn't work for everybody. If you are somebody who already takes some medications, regularly every day, and it would be much easier for you to just add one more pill to your pile, then that's still perfectly fine. It's really about what is ideal for each patient. So there's not like one perfect method for everybody. So.
Well, if there were a perfect method for everybody, we would all be doing it.
Right?
We would all have signed up. Yes. And then so I'm assuming just off of this conversation, Suzanne's now asking, how do we know if the dosing is too high? It's still the same, right? Monitoring symptoms.
And in general, we match the progesterone to the estrogen dose. The progesterone is primarily there to protect the lining of the uterus for women that still have a uterus. So the estrogen can overstimulate the lining of the uterus and cause problems. The progesterone keeps that from happening, and it really keeps everything safe and balanced at the uterine lining. And that's really the main reason that we use progesterone. And so the progesterone is generally dosed to sort of balance the estrogen. So the 100 versus 200, it's usually based on the estrogen dose as to which of those we decide.
Okay. Oh, we have some follow-up specifics. So Sue is asking, following up to the previous question about knowing if the dosing is too high, how do we know if 200 milligrams of progesterone is the right dose versus 100?
Oh, so I cheated and read ahead. Sorry.
Oh, you did. It's okay. That's fine. That's fine. Okay, so we've kind of answered that. Okay. Wow. Anybody else? Suzanne is typing, but it looks like we're at the end of our questions, which has almost never happened. Suzanne. Oh, she says she's read that the transdermal progesterone is less effective due to its chemistry. Is that true? And if so, do you have an estrogen cream or another progesterone form?
You want me to take that?
You want to take that one?
So the progesterone is a much bigger molecule than the estrogen. And so it doesn't absorb quite as well through the skin as the estrogen. However, it's still when done correctly, absorbs enough through the skin to keep everything okay and to keep everything safe. So the premise of your question is not wrong, that transdermal progesterone is a little trickier and it has to be done right. That's something that we're extremely careful about because, again, if you don't do it right, you can cause problems. So we make sure that the dose of the progesterone in the cream is really adequate. And we also use micronized progesterone, which absorbs better. So when done correctly, the transdermal progesterone works just fine. It works really quite well, and it's very safe. You will see things online that say, be careful of transdermal progesterone, it doesn't work. And in fact, if you look at the ACOG and the NAMS, those are some of the big organizations for women's health. If you look at their recommendations, they'll say you need to be really cautious about transdermal progesterone because it may not be adequate. And you know what? If I was writing that, I'd write the same thing because they're right. You do need to be really careful. And at Winona, we are. But there have been problems. You can go on Amazon and get a progesterone cream. And honestly, it's progesterone in name only, because in order for them to sell it over the counter like that, it has a teeny amount of progesterone in it. But the problem is women have been misled, and they're taking estrogen and they get this progesterone cream off the internet that's non-prescription, and they think everything's okay, and it's not, because it doesn't have enough progesterone to protect that uterine lining like I was talking about. And ultimately, they've had problems. And so that's where these warnings are coming from, and they're appropriate. with Winona, that's something we're like anal about this, really, because we really want to make sure that we protect your health. And so we make sure that the dosing and the type of progesterone in the cream is appropriate. And I can tell you, we'll be 3 years in April now. We really haven't seen any problems with our progesterone creams, and they work quite well. So it's kind of a long answer to your question, but that's the sort of the bottom line.
Well, we're very thorough at Winona, so yay.
And by the way, if you feel more comfortable with another form of progesterone, we do have oral progesterone capsules. And so we can prescribe an estrogen-only cream and an oral progesterone. And I have patients that are on that because it makes them feel more comfortable, and that's great. That's totally okay too, and it works just fine that way. So that's another option.
Okay, Susan wants to know, what is the efficacy of progesterone vaginal suppositories?
Well, so in general, most hormones applied to the vaginal mucosa are typically locally absorbed. So, we use progesterone vaginal suppositories for a lot of reasons in OBGYN. Specifically, we use them in pregnancy a lot because it's locally absorbed to kind of help stabilize the cervix for women that were worried about delivering early. But I don't know if I would trust it enough to use to protect a uterine lining, because I don't know if there's enough absorption for it to get to the levels we need it to be.
Well, that is our last question. Unless somebody else is going to write in, this is your opportunity, everyone. You have 5 whole extra minutes to ask us anything that you want. Well, within reason.
You can ask.
You can ask, but you might not answer.
No, the answer may be, I don't know. What's the winning lottery numbers?
Right? We're here.
If I told you, it would dilute my card.
Right? Oh my gosh. I think we have Sue is typing. I feel like we should have some hold music playing.
I think it's kind of fun, the technology that way, that like we can tell somebody's typing. I think that's kind of cool. I always thought that was
like when you see somebody starting to text you and it says they're typing.
Yeah.
Yeah. But then when they stop and then they don't finish, it's like, wait, what?
Oh, what happened?
What were they going to
Right. Right.
You know what? Somebody that started a text and then erased it, it's probably better I didn't get that.
Right. Oh my gosh. Oh, okay, Sue. She says, how do you differentiate Winona from other online menopause medical providers?
Apart from the fact they don't have me and Dr. Cat.
Aside from, there's a whole bunch of things that are positive. I don't know what.
We have a lot. We have competitors, and that's great. Actually, it was funny. I was just talking to my wife about this today. Gosh, it's been a while ago, maybe 6 months, a year ago, in one of these Q&As, somebody had asked about some nasty thing that one of our competitors said about us. And I said, well, that's really too bad. I'm not going to reciprocate because I'm glad there's other companies out there helping women with this. And that's great because it means more access. And competition is a good thing because it makes all of us work a little bit harder and do a little bit better job for you. And so competition is good for patients. I, of course, think we do the best. We strive to really emphasize safety and customer service. We have an amazing patient services team, along with an amazing group of doctors.
I second that. I mean, our patient services team is above and beyond. Like, they do amazing things for our patients.
Yeah.
Yeah. And the other thing is, we do supply the compounded creams, and that's an option that I think most of the other companies don't. So it gives you one more choice that may or may not work better for you, but options are good. I think we're a really strong company. We do our best to really do things well and safe, and give you a good experience on top of that. I have some docs that have come over from other companies, and they're really happy with the way Winona works. Not other menopause companies, but other telehealth companies. So, it's something that we really try to be patient focused and do a good job for you. But there are other good companies out there as well. So I'm not the kind of person that's going to bag on the competition, because it's great that, like I said, the more access, the better. But I think we strive to be the best. And, that's really our goal.
Yep. Well, I think we have actually made it through a whole webinar ending on time. Wait, Jen, she's going to put us at the 5:30 mark. Let's see. She says, what is the highest dose of estrogen you typically prescribe for someone in perimenopause still having fairly regular cycles?
I mean, I think this is dependent on the patient and their constellation of symptoms. But generally, my rule of thumb is that I start kind of low and titrate up as I need to really get somebody's symptoms under control. So what might be a good dose for one patient may not work for another. It's not like there's a certain threshold we have to meet in order for your symptoms to be under good control. So, I don't know if it's worthwhile or if it's useful for you for us to talk about numbers, because it really is such a unique thing for each patient.
Yeah, and I agree. I mean, I think the goal is, if anything, to underdose you at first, because I'd rather not quite get a hold of all your symptoms than cause you a bunch of bad side effects. So it's better to titrate up than titrate down. So that's kind of the philosophy. We try and hit it right, but if anything, we undershoot a little bit because we don't want to cause problems. But we, I have patients on relatively high doses because that's what their body requires. And I have patients that just need a touch and that works for them. So it's really very individualized.
Sue wants to know, do you, Dr. Green, oversee the prescriptions or provide guidelines? Her assigned doctor is not on this call.
So yes and no. My philosophy, my third year in practice, I got a job where I was in a supervisory role. So I've been sort of hiring and firing doctors most of my career and been sort of, in charge of a group of docs. And my philosophy has always been that I hire really good docs and I don't tell them how to practice medicine. So I'm not a big fan of, say, like the Kaiser system. The Kaiser, you do it the Kaiser way, and if you don't, it's the Kaiser way or the highway. And so you're sort of told how to practice medicine. And hey, if that's the way you want to practice medicine, that's great. And Kaiser does a reasonable job. But it's not my philosophy. I really believe in an individualized approach. And so I try and hire doctors that I think are going to do a really good job. And then I let them do their really good job. On the other hand, this has been my life now for quite a while. It's all I've thought about and done, and I read everything I can get my hands on. And so I know more about this than most. And so we use a messaging platform, and I'm available probably more than is healthy for the doctors to ask me questions. I can tell you, so we live up in the mountains by a local ski resort. So my wife and I, we usually spend a couple hours, 2-3 days a week skiing. So I answered a question from one of my docs. I saw it on my watch and I told my wife, well, I got to answer this, and got off the lift and I typed back an answer. So I'm probably more available than I should be, and mentoring the Winona docs and helping them with some of the more difficult questions. So, there is, this is an area where it's specialized and there's a lot of expertise. And, because I've been doing this now kind of as my life for so long, I have a lot of experience and expertise. So on the one hand, I let doctors be doctors. On the other hand, I do help mentor and guide them. And we do have sort of guidelines to follow. Safety, that there's no compromise on, but there's a lot of different styles and right ways of doing things. And so, the different doctors will have somewhat different approaches, all within, some guidelines and of course safety. But that's sort of how it works.
Okay. Suzanne is typing. We'll see what she has to say. But yeah, Winona is very personalized. I think it's one of the best things about being a Winona patient is that you get a lot of individualized attention, and prescriptions are made that way too for you. The compounding process is something that you should all come next month and learn about, because we're going to be talking about that. So if you're curious to know what compounding is and what that means for you, aside from whatever general knowledge you might have, you're going to want to check it out, because we're going to have
is Joshua going to be here? Oh, awesome.
Next month.
Oh, that's exciting.
Yep. We're going to have a nice chat, all of us, with him. You're going to ask your questions about compounding, and hopefully everybody will be very educated by the time they leave about.
So yeah, he's a PharmD compounding pharmacist, oversees a lot of our pharmacy. He super nice guy, but brilliant, like one of the smartest guys I know. It's going to be a great conversation, and I really encourage you. I'm excited.
Yeah, so everyone bring your questions for next month about compounding, and we will still answer some questions that aren't about compounding. So don't feel like if you don't have a compounding question, you shouldn't come, because we want you to attend with all of your questions, but we're just going to structure it a little bit differently, the flow of the event. But please come, it'll be great. And yeah, if anybody else has any last minute questions, we're still here to answer them. So in the meantime, do you guys have anything else you want to oh wait, hold on, Suzanne's message has come through. She's thanking us. That's good. She came to Winona MHT through unfortunate circumstances and had to fight Kaiser after being refused treatment. Started Winona and had a great response to the compounded cream, and finally got a prescription through Kaiser very recently, but not sure about it. She says she may come back to us. So,
well, if what you're using is working, that's great. If not, we're very happy to have you back. Just want you healthy and feeling your best. That's the most important thing.
Absolutely.
Yeah.
On that note, I have to run because one of the other docs has 2 people pushing, so I might have to go catch.
Oh my gosh.
Go catch a baby.
Okay. Thank you both.
Thank you so much for coming.
Yeah.
Thanks, everybody.
We'll see you next month, everyone. Thank you again. And yeah, we'll talk to you soon.
Good night.
Bye, everybody.